morning, everyone. I'm going to present a success story of our emergency department, which happened on 9th of April. There was a patient, Mr. Peter Paul, whose age was 46 years and who was a BSF constable by profession. He presented to our emergency on 8th April at 9 p.m. with complaint of retrosternal chest pain radiating to left arm since 11 p.m. 7th April. That is, the window period was 22 hours. He presented out of window period, and on primary assessment he was stable. Respiratory rate, saturation, BP and pulse rate was normal. His ECG showed ST elevation in V2, V3, V4, V5 and 1 in AVL. Also, there were ST depressions in 3 and AVF at presentation. There were no block as presentation and features were suggestive of anterolateral wall MI. As he was vitally stable, conservative management for anterior wall STEMI was started, and also he had on BBG he had a high 9-cat metabolic acidosis for which a treatment was started in Red 4. Yes, sir. So he was being monitored and treated for decay in red area 4. He was completely hemodynamically stable and there were no complications of MI initially and for the next few hours also. This was the ECG on 9th of April in the morning. There was mild RBP pattern started, but otherwise the ECG was same only. And there were ST elevations in V2, V2 to V5 along with 1 in AVL with development of Q waves also. Sir, here, sir, RS pattern is there in V2, V5, V6. No, sir. This was the ECG in the 9th of April in the morning when he had mild diabetic ketoacidosis. Later on, so it was a busy afternoon shift and Mr. Peter was resting on his couch comfortably. When we asked about his well-being in the beginning of the shift, he replied happily that I am perfect. Just tell me when I can be discharged. Uh, then after some time, Jamshed sir came for rounds and we started reviewing cases in all areas with him. While we were seeing a patient just next to him, he became suddenly unresponsive in a blink of an eye. And monitor showed asystole, then the carotid pulse was absent. We immediately started, code blue was announced and high quality CPR was started immediately. After 2 cycles of chest compressions and breath with bag and mask, ROS was achieved. He became conscious, agitative and uncooperative and so immediate endotracheal intubation was done. Course in emergency after ROS was he developed shock and complete heart block. We started inotrox and transcutaneous pacemaker with successful electrical and mechanical capture. His hemodynamics improved after 1 hour in ED. This was the ECG after his revival, which showed complete heart block with narrow escape. At this time, his BP was 120/70 on ADR infusion and pulse rate was 70 per minute on pacemaker. The ECG was taken without pacemaker. So we can see there is a complete heart block, a P wave here with no relation with the QRS complex. The QRS rate is around 40 and it is narrow escape as we can see. The QRS complex is only 3 boxes here. It is only 3 boxes wide. And after that, bedside temporary transvenous pacemaker was inserted by cardiology team with successful electrical and mechanical capture. After 2 hours, his saturation was 100%. He was on mechanical ventilation, and BP was 117/70 on ADR infusion. GCS was E4 VTM6. Cuff reflex neck holding was present, and he was following all commands. Bedside echo revealed anterior septal and inferior hypokinesia. He got admitted in CCU. Complete heart block resolved after 3 days and temporary pacemaker was removed. He was discharged from cardiology and now planned for angiography for after 2 weeks. In this case, learning points are that third degree heart blocks occur after 12 to 24 hours after anterior wall MI, and it is usually preceded by morbid type 1 or type 2 block. In this case, these previous blocks were not there, and third degree heart block occurs due to extensive septal wall necrosis of bundle branches. This is a feature of escape rhythm following third degree. In our case, we had complete heart block with narrow escape. So the interesting point in this is this table is comparing proximal conduction system with the distal conduction system. In this, proximal conduction system is affected. The QRS width is narrow, which is less than 0.12 seconds, and the escape rate is 45 to 60 per minute, and it may be low as 30 per minute. And the rate is usually stable. Asystole is uncommon. So this was a very rare, uncommon presentation where we had narrow escape and patient developed asystole. And in our case also, the complete heart block resolved after 3 days, and which is the scenario in these kind of patients. Otherwise, in complete heart block in wide escape, the heart rate is often less than 30 per minute, and rate is unstable with moderate to high risk for ventricular asystole. But the duration of high-grade AV block is usually transient, but some form of AV conduction disturbance and intraventricular defect may persist. We had, as I said, there was intraventricular defect, so there was overlap between the two, but the patient survived, and we successful resuscitation was done by the team, and the patient was discharged and revived. Now he is alive and following up in OPD.
How the transvenous pacing was done in the AD?
The transvenous pacing, actually, the cardiology team planned it to do in the cath lab only, but we didn't have transportable transportable defibrillator, which can but pacemaker pad for that pacemaker was not available.
क्या नहीं था?
The pacemaker was not available for that defibrillator. The battery was not available that day. But that required continuous supply only. The defibrillator, which had compatible pads, that was not transportable because of the battery issue. Well, actually, cardiology team agreed to put transvenous pacemaker bedside only.
No, that's what I'm saying. How? My question is easy. It is not a difficult question. No, he put the transvenous pacing on the bedside. Patient, having coming in arrest, cardiac arrest. The next level is you doing the transvenous pacing. So that is what I will be most happiest if my student does the transvenous pacing. You understand? एक मिनट बेटे है ना, तो because the case is there है ना, so I have to make that point. हमें बड़ी खुशी हुई, patient has gone back. This is just like that celiac ganglion block patient that Dr. Nair was just saying. The opposite side of the spectrum. You understand? It's complete heart block. Again, the critical procedure here is the transvenous pacing. We are doing the temporizing measure, जो हम आपको पढ़ाते हैं ACLS में, transvenous pacing लगा देना ये. This is the basic. है ना, बेटा उन्होंने कैसे डाला ये मैं पूछ रहा हूँ ना, ये बताओ तुम मुझे. हमारे पास भी है.
So they clean the area and then access the vein by using ultrasound. Femoral vein they access.
So you can do that. अभी आपने देखा.
Simple vein puncture was done, and pacemaker guide wire sheath was inserted, and then pacemaker wire was inserted, and then confirmed with the echo.
Echo. डिफॉल्ट में देख सकते हो आप, है ना? अरबी तक आना है ना आपका?
Yes, yes. By seeing the IBC first, we
आईबीसी भी देख सकते हो आप. Then
then they visualize the echo in the four chamber view first, and then confirm the position.
वो चैम्बर व्यू आप एक्सेलेंट हो देखने में, है ना? So there is no way you can't do anything. You know, right from femoral vein, you can go to the iliacs, right? आप पूरा देख सकते हो आईवीसी नीचे से ऊपर तक. कंटिन्यूअसली देख सकते हो ना. लॉन्गिट्यूडनल व्यू में भी देख सकते हो. गाइडवाइज जाते हुए, है ना? यू आर द बेस्ट पर्सन. एब्डोमिनल एओर्टा स्कैन वो नहीं कर पाएगा, बट आप कर लोगे. उसके बगल में तो है ना आईवीसी. और जैसे जैसे जाएंगे ट्रांसहेपेटिक व्यू देख सकते हो. So you can, just like a fluoroscopic image, you can go up to here. Then you can go to the right atrium and right ventricle. दोनों देख सकते हो आप through echo, है ना? four chamber view. नहीं? Only the question होगा हमारे पास पकड़ लिया. तो हमने कहा भी तो है last time.
That debate was going on whether
And best part was Dr. Nair was there. है ना? He could have just stood there and he could have done. अरे तुम्हें करना था मुझे करनी है. ठीक है ना? Do it. Patient is demanding now. Why you have to give the procedure to other people? Basically, then what is the difference between you and them? Understand? So emergency medicine, there is a power. Just do it. यही है next level जाने का.
actually at that time transcutaneous pacemaker was also inserted. ECG simultaneously they didn't do. Simultaneously they didn't do, but after placing it, they confirmed it.
The better one, see, समझ करेंगे वो भी. Where a meter which is better than the cardiologist, it can in fact override the things, override the things. ठीक है ना? It is, though it is very old one, it is purchased in 1994, it is still working. Right?
I would like to share one story, sir.
Yes, sure.
Red one में there was some patient CSB was unstable. So cardio sir brought the setup of
Primitive setup.
from their board. So he brought that and also he tried doing it blind. So blindly he has done for like almost 3 to 4 times. And after 3 to 4 times he punctured it and he was not getting vein. So multiple times he punctured the artery. So he did not get vein. So finally Rakesh sir was seeing the dental. And with ultrasound he tried once, but he was not able to like maneuver around this one, sir. So Rakesh sir told I will do that. And the anatomy was the femoral artery, the femoral vein was below the femoral artery, sir. So it was difficult for him also by applying it. So Rakesh sir like tried it in this one, sir. Normally under guidance he has done it and also placed it. And finally he could like and the entire procedure was like. Cardiologist are told you do it, okay? So he has done the entire thing. Like after that, everything, sir. So he has given. So because he did not know how to do the ultrasound guided. Yes, sir. So first of all, like after placing here, so he has placed the guide wire and then after that, the electrode, the lead was placed. Then after that, he has seen the IBC in that one, sir. So after that, he has seen the IVC, sir. IVC mein that lead is given here. Then after that, in the RV, so then they are connected to the everything, sir. And they are given. So and after that, the patient has connected to the device. This was 8 months back in Melbourne, sir.
The other story is you must do it yourself. But इसका point of care ultrasound में इसका पकड़ लिया, very okay.
And also, guardians are was not able to. In CCU में also they do like they are not.
But they do under fluoroscopy generally. They do guide it. Different guide only. Multiple guide. Except the blind setup.
This patient is different.
Okay, anatomical variation. JB के थ्रू देते हैं हाँ इसीलिए नहीं कर रहे हो पर टेम्पररी में तो कर ही सकते हो गाड़ी गैस में है CPR चल रहा होगा ठीक है ना तो बेस्ट से टेम्पररी से भी निकाल सकते हो नहीं तो बेस्ट से भी ठीक
And it's very simple, like after placing the electrode was good there after like R so 4 camera
पूरा IBC का जो ट्रैक है आगे इसने कैप्चर करके चला गया
आप लोगों का कदम हो गया था प्रदेश में सीधा
लेके तो आज मैं कर लूंगा नो वन इज नोइंग वेयर इट इज कहां पे रखा है मुझे कोई आईडिया नहीं है
fitness का everybody is in the OT area. It is in game covered.
देखो मांगना है
क्योंकि मैं आई वाज
Just as the OT system, just as the OT system.
पॉइंट ऑफ कांटेक्ट